Rajshri ma'am is there, Dr. Jayant is there. So one of them can introduce the speaker. I think Rajshri ma'am would be doing the honors.
I'm waiting
Both
for to
of
introduce. He's
yes.
my college senior, and I'm so happy today.
Thank you so much, ma'am. Thank you for being here. So both of you can talk about the topic, initial opening, and then we go to Dr. Sarnik, and then question answers will be there. So we are starting now. Everyone will be on the full screen, please. So good evening, all of you. Welcome to this 290th edition of Thursday Musings. We have an expert in the field to talk about cannabis use in people with major mental disorders, effects, and potential intervention approaches. So this is on the Zoom platform. This meeting is being recorded. This will be put on the YouTube for later viewing. The question and answers are invited in the chat box. So you have to type and post in the chat box, which will be taken up to the resource person. Next slide, please. I'm handing over to Professor Dr. Tufan Pati, sir. He is the chairman of this program. Over to you, sir. Not reading your CV.
Thank you very much. Thank you very much for not reading the CV also. And welcome to this meeting all. And I welcome to this meeting our moderators, all of my friend, Dr. Lim Siddiqui, Dr. Amrit Patadosi, and Dr. Vishal Shah, and Dr. Sobit Kar, who are here. Slides. Shreya, please. Tell us about the slide. Lim Siddiqui, Sobit Kar, Dr. And our chairperson today is Dr. Jayant Mahadavar. He's MBBS from JIPMER, MD from JIPMER, and DM Addiction Psychiatry from NIMANS. Designation is Assistant Professor of Psychiatry, the Center of Addiction Medicine, Department of Psychiatry, National Institute of Mental Health and Neurosciences, Bangalore. His areas of interest involve vulnerability to addiction, co-occurring mental illness and addictions, behavioral addictions, and psychiatric genetics. He has 75 publications, 62 articles, 15 chapters, and 2 books. Citations 646, H index 12. Awards, current Young Scholar Award, National winner, DNP Gold Medal in Psychiatry 2014. Welcome, Dr. Chan. Next slide, please.
Thank you, sir.
Welcome, Radhasri. Welcome. MD FRC Psych, CCTOK, Adult and Addiction Psychiatry, PGDA NLS Bangalore, Professor of Psychiatry, Param Samman recipient from Government of West Bengal, India, Honorary Member of World Psychiatric Association, Chair of South Asian Division of Royal College of Psychiatrists, UK, Secretary Section on Religion, Spiritual and Psychiatry, WBA, and Chairperson of IPS Foundation Day Subcommittee, ex-Chairperson Spiritual and Psychiatric Special Section of IPS, and dancer and artist by passion. Welcome, Dr. Radhasri. I request Dr. Radhasri to introduce our speaker, and both of you can give the initial comments to the topic. Please take over the chairpersons.
Thank you so much to the organizers for inviting us to this 290th episode. It's a marathon innings, and first of all, congratulations to all the organizers. And it indeed is a very proud and a happy moment for me to introduce none other than Professor Shagnik Bhattacharya, whom we have idealized, and from when our first year in medical college in Kolkata. He happens to be 5 years my senior, so you can imagine the fifth year bright, and he was always so bright. But I think what is important is for me to introduce him formally. Sir is a professor of translational neuroscience and psychiatry and the deputy head of the Department of Psychosis Studies at the King's College London. And alongside, he's a consultant at the South London and Maudsley, the Slam Foundation Trust. At the moment, Sir is ranked #2 worldwide amongst the biomedical scientists working on cannabis and has been employing experimental medicine approaches in conjunction with neuroimaging and pharmacological challenge to understand the neurophysiological and the neurocognitive basis of the effects of both the compounds. His work has provided the first human evidence of the distinct neurophysiological effects of the two major cannabinoids present in the extract, and proof of concept evidence that cannabidiol, the CBD, may have therapeutic potential as an antipsychotic. Sir's group is now leading the RCT, investigating the efficacy of cannabidiol in different stages of psychosis, as well as in neurodegenerative disorders such as Parkinson's disease. He has published over 170 peer-reviewed articles, including in the World Psychiatry, Lancet, JAMA, and BMJ, with an H index of 65. But more importantly, he's such a learned and down-to-earth person. If you hadn't seen his CV, you'd hardly realize that he's got a person with a human touch. And on that note, I'll invite my co chairperson to say a few words on the topic for this Thursday musing. Over to you, sir.
Thank you, Professor Rajashri, and thank you once again to the organizers. I'll be very brief. I think the topic is, of course, extremely important. I mean, I think specifically given the context, I think the world is currently moving from a stance which was mainly related to prohibition of recreational cannabis use to more regulatory regimes. And one of the outcomes of this, at least in epidemiological literature, is that there have been rising concentrations of THC in cannabis products that have been seen from around the world. I think there's fairly convincing evidence that THC concentration is associated with increased risk of psychosis. But of course, as was mentioned in the previous slide as well, the cannabis plant has numerous other phytochemicals apart from THC. And I think we will get to hear a lot about the work that Professor Shagnik has done in the area of CBD and some of its therapeutic effects and how it modulates effects of THC. I've had the distinct pleasure of having listened to Professor Shagnik on two occasions previously, one during a conference that we had organized and one talk in person, which Sir had given fairly recently at NIMHANS. So really looking forward to hearing more about all of the work that Sir has done over the last decades. So over to you.
Thank you, everyone. Firstly, Rajashri, you make us proud with your achievements with the Royal College. So thank you for the invite to both you and, of course, to Dr. Aleem, Dr. Garg, Dr. Patajoshi, Dr. Topanpati, all of you. Really grateful for this invite. I'm really pleased to be here. And Jayant, it's lovely to see you once again. So thank you. If I had realized that you guys will put it all on a slide, then I would have not shared my bio sketch in that manner.
You're available online anyway if we Google you. So all the details are there.
Okay, let us move on. I think, Jayant, this will be a little bit different from what you have heard before because Dr. Aleem suggested to me that I should focus on more clinically relevant bits. And he wanted to kind of, I think, what was it? I think you mentioned that you usually want speakers to share their wisdom. Now, I understand that sentiment, but I think perhaps in this gathering, there are people with far greater clinical experience and wisdom than I do have. So I'll stick to my line. I'll stick to the straight and narrow. And what I'm going to do is perhaps talk about some of my work and work from colleagues, which perhaps will give you a framework to think about why you are doing whatever you are already doing. Perhaps give you a framework to explain the rationale for what you are doing clinically anyway. There will not be any new revelation. And I will kind of, in the course of this talk, perhaps explain why we have not progressed very far, despite all that I say in my, that bio sketch. So I am a clinician, but also teaching and carrying out research. So this is how I have thought about how I'm going to focus over the next half an hour, 40 minutes or so. So I'm going to talk about why the interest in cannabis and psychosis, why is it relevant to the listeners today? What do we know about its effects on outcome in people with psychosis? The reason for focus on psychosis is, to a certain extent, because that's one of the major areas of my own research and clinical interest. So to a certain extent, that's something I'm far more comfortable with, at least over the last couple of decades. That's what I have been mainly working on. Then touch upon how cannabis use might be affecting outcomes in people with psychosis. So dwell on that a little bit. Hopefully, that'll give us some insight into what it might mean for patients and perhaps most importantly, clinical practice in your daily life. So that's how I've kind of thought about it. And then, of course, very happy to kind of take any questions after that. Now, I don't know whether the top of the slides are visible here because I can't see it. So what I have put here is I'm going to show a case vignette, which may be very familiar experience with clinicians. So I don't expect you to read that fine print there. So I have made it bigger here. Hopefully this is more legible. So this is a comment left on the Vice News website. I don't think the Vice News website exists anymore. So such are the ways of the digital world. So it has gone out. It was very fashionable about a decade ago. And there was an article on the Vice News website following one of our publications, and there were a lot of comments from different people, and this was one of the comments left by somebody who had looked at the article on that website, looked at the commentary about our article on that website. So this young person is saying that I was a friendly, happy kid, as many do. I started smoking light drugs at 16. By 21, I used to smoke, let me see, I can't see part of it. I used to smoke 10 joints a day. When a similar thing happened, I had to level up. I stopped smoking drugs and did medication. And then they go on to say how things improve. But then when they smoked cannabis again, the symptoms returned. So this is something that I see very often clinically. I don't know how common experience that is. Wow. Okay, let me see. The slides are not moving. Sorry, I think because I have moved the top panel, I think it seems that the slides are not moving now. Hopefully it will move now. Yeah. So I have a kind of question for everyone. So if you kindly, those who have a mobile phone, if you kindly scan the QR code and try to answer this question that I have there for you. Sorry. So whether this vignette really rings a bell, is this something that any of you see in your clinical practice? So if you kindly answer that, and then there will be the next question.
Sir, how would you like people to answer the question? Raise their hands or?
No. They can answer using their mobile.
Okay, using their mobile, scanning it up. Yeah, sure.
Yeah,
okay.
Scan the QR code, so it'll take you to the questions, and you can answer. So I'll move to the next question as people keep. Okay. Right. So it's not an unusual situation in your clinical practice. So a fairly common experience for many clinicians, at least of those who have submitted their responses. Okay, so please carry on with that. I'll move on. So I think this is just to reassure me that this is not something that is not of interest. And that really aligns very well with the most recent report from India. This is from AIMS by colleagues at AIMS who did this survey on behalf of the government of India. And that really is in line with the data from the rest of the world that cannabis use is very common. About just under 3% of Indians between the age of 10 and 75 use cannabis. It's the second most common psychoactive substance after alcohol. And it's mainly bhang, but also ganja and charas. And the map on the left side really shows the prevalence rate of ganja and charas use in different states of India. So, which I think says that it is a problem that is not geographically limited, though perhaps some states seem to be closer to the 0%. So I don't know whether it is a result of the vagaries of data collection or it's actually a true picture. Nevertheless, let's move to the next question. Again, another question for you. Cannabis use is common. It seems that it is common in the clinical practice of people who are attending this webinar. But which of the following outcomes do you typically see to be associated with cannabis use? Mind you that this is a slightly different question. The previous question was, in what kind of psychiatric presentations do you see cannabis use? This is more about outcomes that may be associated in your clinical practice with cannabis use. Okay, so that's really, really interesting. So while you are completing that, let's move to the some evidence. So all the while we were looking at more anecdotal evidence from your clinical practice, and this is systematic evidence. This is very dated now, so nearly 20 years old from a meta-analysis. I'm not going to go through all of it, but we can come back to that if anyone has an interest. I will try to stick to the take-home message from that. And the take-home message really is that those who use cannabis fairly regularly, they have really double the odds of developing psychotic disorder as shown here. This diamond shows the odds ratio of those who are regular cannabis users. So double the odds of developing a psychotic disorder if they happen to be using cannabis regularly for long periods of time. So, of course, it means that it increases the risk of developing psychosis. We are not talking about whether it is causally, it's a causal association. We won't get there just yet. However, although I'm going to talk mostly about cannabis, this is just to indicate that it's not just psychosis that's one of the outcomes that is associated with cannabis use, but other major mental disorders are also, and behavioral problems are also associated. And this is just another example. This is from a cohort study of around 400 young men who were followed up from age 8 until their 50s in the UK from a defined geographical area. And essentially what it shows is that there is a kind of association with continued cannabis use and increased risk of developing major depressive disorder. And the risk is greater in those who start using before they are 18. And again, it's not just depression and psychosis, but there is a similar risk of violent offending in those who tend to use cannabis regularly over their life course. Again, this data is from the same prospective cohort study of 8-year-olds followed up until they were 56. And similar kind of association. And we can, if anyone is interested, we can go into that in greater detail. But just to say that there are a number of adverse mental health related outcomes that are associated with cannabis use and not just psychosis. Although we will stick to that. And over the next few minutes, what we are going to focus is that, okay, in terms of psychosis, what do we know about the effects of cannabis use on outcome in people who already have a psychotic disorder? Now, again, what I'm going to show you first is the results of a meta-analysis. And again, this is fairly dated now. It's about 10 years old. This is from our work. And essentially, this is pooled data from around 16,000 patients with psychosis from different geographical regions in the world, different countries. And the key take-home message from this is that those who use cannabis regularly, that is, those who continue to use cannabis, are at greater risk of relapse of psychosis, as indicated by hospitalization, than those who do not continue to use cannabis. And this is the kind of pooled odds ratio, pooled effect size of the effect of cannabis use, suggesting that there is a significantly greater effect of cannabis use on poor outcome in people who already have a pre-existing psychotic disorder. But of course, this was a meta-analysis, so where we are pulling data from multiple studies. Each of those studies have their own problems. They are done in different settings. They may have different designs. So they are very heterogeneous. And as I said, they might have their own problems. So when you are pulling the data from all of these studies, although the numbers are huge, 16,000 patients worth of data, the heterogeneity of these studies, the methodological issues of these studies poses additional challenges. So you're not sure at the end of it that how much confidence can one have on this pooled results, because the studies may not have always control for potential confounders. So for example, people who use cannabis seldom use cannabis on its own. They may use other drugs. The participants in the studies may be of different ethnicity, may be of different sex. Their illness might have been different to start with. They may or may not have continued to take medications. And all of these are factors we know that they also have an independent effect on outcome in the long term. So just pulling it all together, lumping it all together, doesn't mean that we can have real confidence that that is the true picture. And of course, another important thing is that, and this must be familiar to many of you, that there is a common kind of understanding that many people with psychosis use cannabis as a way to treat the side effects of the antipsychotics they are on, or treat other aspects of their illness. So the self-medication hypothesis. So whether in these studies, whether cannabis use preceded relapse or the onset of psychotic symptoms, or whether psychotic symptoms predated cannabis use, all of those questions are really important to resolve the question of whether the association that we find, is that a causal association, or is that just, that when there are when it is the month of June, July in India, May, June in India, it's summer, but it's not that the months induce summer, it's various other factors as a result of which climate change, the weather patterns change, and that's why summer is there when it is the month of May, June. So is that a causal relationship? That is not resolved. And most of these studies discussed about cannabis as if cannabis is just one substance. But of course, it's far from the truth. There are different types of cannabis in India. It's something very familiar that people use bhang, people use charas, ganja. But then if we go deeper, we know that there are over 150 different cannabinoids in the extract of the plant. There are lots of over 400 non-cannabinoid chemicals in the extract of the plant. So what one person might be buying in the streets of Calcutta might be quite different from what one might be buying in the streets of Gurgaon, as opposed to what one might be getting in the streets of Bangalore. So it all depends on where you are getting, who is your supplier. However, none of these studies took all of that into consideration. So we wanted to kind of look at this more systematically. The first study that we did, we were more interested in getting a big data set because the smaller, most of the studies that we pulled together were smaller samples. So we wanted to look at as big a data set. And this, at that point of time, was the biggest data set of psychosis, patients with psychosis in whom we looked at the effect of cannabis use. I don't want to go into the details, but if anyone is interested, we can come back to that. I think the key take-home message is that, and again, I'm not going to bore you with all the bar charts here, but I'm going to kind of summarize the key findings that we found. So here we looked at cannabis use very simplistically. We looked at all patients attending the 4 clinical services for early intervention in psychosis within the South London and Maudsley NHS Trust. So that caters to a large population in the southeast of London, so 4 boroughs of London. And so we looked at all the patients who had presented to, and because the NHS is the primary provider of care, so we were kind of looking at most of the patients with psychosis in that catchment area. And we looked at them over 5 years of follow-up, and all the patients who had at least 1 year of follow-up up to 5 years of follow-up. So we started with about 2,000 patients, a little over 2,000 patients. And the key message is that, and kind of in terms of cannabis use, we looked at a very crude measure of cannabis use as part of, because cannabis use is particularly problematic in this part of London. So nowadays, residents and clinicians are much more used to asking about cannabis, documenting history of cannabis. It's not a fairly detailed documentation. It is just at least yes, no kind of documentation. So we thought, let's look at just yes, no cannabis use documentation. And is there a greater risk of poor outcome in those who had endorsed cannabis use soon after they first presented with their first psychotic episode to the local mental health services? So within the first month of their assessment, by when most assessments would get completed, so did they endorse cannabis use? And those who endorsed cannabis use, in the top left panel, you can see they had greater mean number of hospital admissions compared to, as shown in the blue bars, compared to those who did not endorse a history of cannabis use at onset. And this is for those who had a 1 year of follow-up, so about 2,000 patients, and then 2 years of those who had 2, 3, and up to 5 years of follow-up. So that's about the number of hospital admissions. When you look at the number of days spent in hospital, this shows the average number of days spent in hospital and how that differs. So on average, by the end of 5 years, patients who had endorsed cannabis use, yes, at first presentation to psychiatric services, they on average, so mind you, we are just looking at, they had just said yes. This could have been people who had just used once or maybe a few times, just experimented and stopped, but they had just endorsed yes. On average, they spent 35 additional days in hospital over the first 5 years of their illness. And this is about something else. So in the UK, it's very common to have compulsory admissions, involuntary admissions in people with psychosis. And this is just to show that and this is where we psychiatrists admit them against their will to inpatient centers. And this shows that patients who endorsed cannabis use at first presentation, they were at greater risk of admitted against their will, being admitted involuntarily. So again, just to say that, yes, there is something there, despite the very crude cannabis measure, yes, no, we can still see very clearly that there is a dramatic effect on outcome in people with first episode psychosis. So these are all people who had been, who entered into the study at the point that they first presented with their first psychotic episode. So everyone entered the study at the same point of time, roughly the same point of time in the course of their illness. So not a very heterogeneous group in terms of stage of illness. And so this is the kind of key take-home message that we also found that cannabis use was associated with increased number of unique antipsychotics prescribed per patient. And we will come back to this a little later. Then it will become clearer why kind of I'm talking about this. So, of course, as I said, cannabis use was assessed very crudely. We didn't take into account some of the other drug users. We didn't take into account types of cannabis that they were using, how frequently they were using, how did they continue, were they taking it intermittently? All of those shortcomings that I had pointed out for most of the studies that had been published up till then, where some of those were still there in our own study. It was a very big sample, the largest sample, but that doesn't mean that it was really a perfect study. So we wanted to then systematically address this because that was on the basis of clinical data that was routinely collected. Then we also looked at a cohort of patients whom we followed by research interviews over at least for 2 years. And what did we find? And in this group, we were able to take into account their type of cannabis that they used, how frequently they were using, were they continued users, where did they stop using, were they intermittent users. And we all took into account other things that we think can have an impact on outcomes, such as how well were they taking their treatments, were they compliant with treatment, were they using other drugs, were they using smoking cigarettes, were they alcohol users, what was their ethnicities. There is some suggestion that certain ethnicities are more sensitive to the harmful effects of cannabis than others. We took into account gender and all of those factors, the most important factors that we think might have an impact on outcome, we accounted for those. And again, I won't take you through this part. This just shows the different relapse events. Every time there is a step, that is a relapse event, and this is over the first 2 years. And you can see that the number of relapses, the proportion relapsed is shown on the y-axis. The number of relapses is highest in those who were continued users, who were using skunk-like cannabis at a high frequency. But that's unadjusted data. I will now present you the summary adjusted results. And the really most important bit is that it shows that relapses were the odds of relapse were a little over 3 times greater in continued cannabis users who were using skunk-like cannabis at a high frequency compared to those who were using cannabis in the past but had stopped using. And this is after taking into account many other confounding factors that one would expect to have an association with poor outcome. One moment, let me just track this. And then when we looked at, also factored in medication non-adherence, because that's a very common thing. Patients with psychosis take medications for a while when they are in hospital, then they stop medications when they're out of hospital, and then they take infrequently. And so we factored that into account, and despite that, the effect of cannabis use continued. So, and you can see that both of the odds ratios were around 3, just under 3 and just over 3. So one way of looking at these results is that if patients with patients with psychosis were to stop taking their medications, the effect that would have on their outcome in terms of risk of relapse or hospitalization is kind of in the same range as the effect of cannabis use on outcome, on poor outcome. That is, despite factoring in the effect of, despite taking out the effect of medication non-adherence, the effect of cannabis use, continued cannabis use, is substantial on poor outcome in people with psychosis. So again, I'm going back to comment left by another person when we published some of this work. And this is kind of blown out so that you can read. So this young person is saying, what a crackpot. People who use drugs often do it to cope with problems. You would find the effect for any drug. So they were saying that how bad our study was. Just because we are saying cannabis use is associated with increased risk of relapse, they are saying that, of course, people use cannabis or other drugs to cope with problems. And you can find that kind of association with any drug. That doesn't mean anything, because this is like saying park benches cause homelessness or that tall buildings cause terrorism. Just because there is an association doesn't mean the association indicates causation. Very right. So they clearly showed us our place, because we were, in their mind, we were overclaim. And again, this was published, this was a comment on Vice News website. So what do researchers do? They go back and they try to address those questions. So that's what we did. Now, what we did was, and I'll try to explain it as much as I can. Now, the really robust way to address that question would be to do a randomized control trial, where you allocate people to cannabis use and to no cannabis use, thousands of people with psychosis. You allocate them to using cannabis or not using cannabis. You ask them to keep everything else constant. You follow them up over a number of years and see what proportion of them relapse, have hospitalization, and then you compare that between the two groups. But of course, we can't do that ethically. Knowing that cannabis is bad for someone's health, we can't ask them to start using cannabis. We can do a randomized control trial with new treatments. We can't do a randomized control trial with an obvious harmful exposure. But that's the only way to answer this definitively. So then we were thinking, how can we do a randomized control trial without doing a randomized control trial? So what we did was a kind of statistical jugglery, if I may put it that way. So we used our observational data and we employed what is known as a quasi-experimental design to address some of these questions. So the first question is, the argument against an association indicating causation in this context is that people with psychosis who use cannabis or people with psychosis who do not use cannabis, they may all have a same underlying genetic or familial vulnerability that might predispose them to both developing psychosis, having relapse of psychosis, and or having cannabis use disorder. But when we compare groups of people with psychosis with cannabis use and groups of people with psychosis without cannabis use, we can't tease that apart. They might be systematically different because of their pre-existing genetic and or familial vulnerability to start with. And so the argument that the pre-existing difference explains the association, we can't get out of that by comparing them as different groups. On the other hand, people with psychosis with cannabis use don't continue to use cannabis throughout their lives. There are periods when they are using, and then there are periods when they may not be using. So there are periods when they come in and out of their cannabis use behavior. Now that gives us an opportunity to use that individual as their own control by comparing periods when they're using with periods when they're not using. And so, because when you are comparing the same individual across two different periods of time in their life, then the underlying genetic and or familial vulnerability doesn't change, because that has been, built in before the onset of the illness. So that is already there. So by comparing them during two different periods of time in their lives, we are saying that we are getting rid of the confounding factor that we can't otherwise control for. And that's what we did. And again, I won't take you through these numbers, but I'll just explain what we found. So, and we did some other kinds of analysis. We looked at various kinds of cross-lag analysis, etc. But the bottom line is that we found that association of cannabis use and relapse of psychosis is unlikely because of shared predisposition increasing the risk of both. So when your patient says, or somebody else says that, look, it's all built in, they are using cannabis because there is underlying genetic vulnerability, and because they're using cannabis because of that, that's why they are at increased risk of relapse. This is the argument that you can use, that no, it doesn't look like that explains everything. And we also kind of assessed in this question, because one of the arguments is that people with psychosis use cannabis as a kind of self-medication. So if that were the case, then one would expect that relapse of psychotic illness would predict subsequent cannabis use and not just the other way around. So we tested that. And what we found was that cannabis use status and pattern of use after onset of psychosis predicts subsequent relapse, but not vice versa, suggesting that perhaps the self-medication hypothesis, it sounds very sensible, it makes sense, but maybe that there is not a great deal of evidence in support of that. Okay, so I showed you all of this, which we did about 10 years ago. So we were feeling great that we have made some good progress. And then I looked at some literature. So this is from roughly 130 years ago, the Indian Hemp Drugs Commission. And this shows, the top panel shows the different drug use that was recorded in those who were admitted to the Bengal Asylum between 1873 and 1893. And they recorded ganja, opium, and spirits. As you can see, opium and spirits were at the bottom, and this was the percentage of inmates who had endorsed ganja use. And then, that's of interest, they were already thinking about cannabis as a problem. But then, something more which was very chastening for us. So this bottom panel, it may not be possible to see. This just shows by different age groups. Each bar reflects a different age group. It shows not just the percentage of those with asylum admissions as shown by the bars, but the line tracks what percentage of them were relapsing. And so, as you can see, hemp's insanity and relapse is not something that in the second decade of the 21st century, we have been finding things about. It has already been documented over 130 years ago. So that was very useful to, bring me down from the high of the weed. Okay, so let's move on. We know that it affects outcomes in psychosis, but you didn't listen to me. You wouldn't have needed to listen to me to know that. I'm sure that most clinicians who see people with psychosis with or without cannabis use, they know that anyway. One doesn't need to read books for that. One doesn't need to listen to this. But how does it affect outcomes? What happens? It's well and good to think about, yeah, something is happening in the brain. It must be affecting the brain. Yes, it might be affecting something in the brain, but that doesn't give us something concrete, something that we can act upon. So we were interested in looking at that. And this is where I think, Jayant, your thing that although neuroimaging is what I do, it's my bread and butter technique, but talk is not about neuroimaging or any of that. This is pure clinical thing that we have been doing. So we wanted to ask, how does it make outcomes worse? Might it be making existing treatments less effective? might it make people less compliant with existing treatments? Now, why we thought about that is that kind of, and again, I don't want you to go through all this, but I'll summarize what this actually represents. This was a study done by led by Deepak D'Souza at Yale. Deepak D'Souza is from Bangalore, graduate of St. John's Medical College, several years my senior. So another Indian person who happened to means we all seem to be gravitating towards cannabis for some reason. But anyway, so what they did was they did the first study where they gave people with schizophrenia cannabis or THC experimentally, and then looked at its effect. And these people were already on treatment with their antipsychotics. They had not stopped taking antipsychotics, and they showed that even a single dose of THC in people who were well treated and continued to be on antipsychotic treatment, they experienced worsening of their psychotic symptoms, even a single dose, suggesting that cannabis can, result in breakthrough psychotic symptoms, even if one is responding, one is on treatment. So the possibility that maybe even if people are on treatment, but if they're using cannabis, then the antipsychotic, their treatment might fail. So that's what gave us that idea. So we want to test that formally. This is going back to the first study that I was talking about, where we looked at 2,000 patients from the Maudsley Trust. And so we wanted to ask, does antipsychotic treatment failure mediate the effect of cannabis use on outcome? And let me explain what I mean by that. In our cohort, I had said that cannabis use using first episode psychosis patients had greater number of antipsychotics, unique antipsychotics prescribed to them. So we reasoned like this. So clinicians, not researchers like me, but clinicians in the real world, when they have a patient with psychosis, they start an antipsychotic, the patient is on that for some a reasonable period of time, then they relapse, and even if the patient is still on that antipsychotic, if they relapse, then they change the antipsychotic because perhaps the antipsychotic is not working anymore. So the more number of such changes might mean the more instances of failure of treatment with a given antipsychotic. So we counted the number of unique antipsychotics patients were prescribed in that study with 2,000 patients. And we wanted to see whether that perhaps explained the effect of cannabis use on increased number of hospital admissions. And essentially, without boring you too much with the stats of it, we found that a significant proportion of the effect of cannabis use on poor outcome in terms of number of hospital admissions was through making antipsychotic treatments not work as well as they could have otherwise worked. So making antipsychotic treatments fail. That's how cannabis use increases the risk of hospital admissions. And this is really showing that this was an effect that was both in terms of number of hospital admissions, but also in terms of number of days present in hospital, and to a certain extent with number of compulsory hospital admissions. So essentially what this indicated is that part of the effect occurs via treatment failure. Now then, of course, that raises the question, why do treatments fail? Why do they not work? Now, so we wanted to look at that. Treatments may not work for many different reasons. It may be because patients are not taking them. That's the most obvious reason. So the first question we looked at was that, might that explain why treatments fail and/or cannabis use is associated with risk of relapse? And so this was the same PhD student who had done the initial, those very elegant studies. She looked at the data, and again, without boring you with all the stats, essentially the key take-home message is that cannabis use, the association between cannabis use and risk of relapse in terms of hospitalization is partly mediated by an effect of cannabis use on medication adherence. So one of the ways that cannabis makes people relapse is because under the influence of cannabis, people are less adherent to their antipsychotic treatments, and that is why they relapse. Now, none of this is, earth-shattering. This is all common sense, but perhaps it has not been shown systematically in that way before. Then, of course, each answer raises a new question. How does cannabis increase medication non-adherence? Now, this is the part that is not published yet. So I don't know, I had not looked at the possibility that this could be recorded. But anyway, I'll take through this. So one of the things that we thought was that we know that people with psychosis, when they are very unwell, that they have poor insight. And it's understandable that when one has poor insight into the need for medication, they might not take medication. So we wanted to see, does cannabis use have an effect on insight, and that in turn has an effect on non-adherence. And again, we do the similar kind of statistical analysis. So this is not published yet. So just take it with a big pinch of salt. It's not peer reviewed. Again, we found a similar kind of effect that's suggesting that perhaps cannabis use affects insight, and that is the pathway through which it makes people non-adherent to their antipsychotic treatments. Okay, all of this is fine, but what does it mean for patients and clinical practice? What can we do about it? So first of all, to summarize, it seems like change in cannabis use represents a robust risk factor for relapse in patients with psychosis. It's very unlikely that self-medication or shared genetic or familial predisposition can explain that association. And perhaps, particularly in the UK, and US and such countries, it is important to keep on having this debate whether cannabis is good, bad, or ugly, that kind of thing, and to move on towards interventions. The evidence is as good as it can get at this point of time. We need to do something about it. It looks like abstinence may be ideal. However, abstinence is not always achievable. Not everyone might be able to abstain. But it seems like reductions in frequency or duration of use or use of less potent forms may also help reduce risk. We didn't have power to systematically look at that, the numbers in each of those groups, but the general trend suggests that. Okay. Now, of course, when you speak to people who use cannabis and say that, yes, cannabis is bad for your mental health, they will always tell you about a lot of people, hundreds of people really, whom they know, who have used cannabis a lot, who have never had any mental health problem that needed intervention, treatment in hospital, or had to go to a psychiatrist. And that's right. Not everybody who uses cannabis has a bad outcome. It's those who are particularly vulnerable who might be at risk of such outcome. So one of the other things that came up in the context of this work is that if we could predict who are most at risk, then one could target scarce resources for those who are going to most benefit from it by targeting those who are at risk. And kind of like a personalized medicine approach. So we looked at developing a risk prediction algorithm. I'm not going to kind of dwell into that, but just to make you aware that there are ways of doing such prediction tools. And this is one way of predicting a given individual who is sitting in front of you in the clinic, what is their personal risk of harmful outcome. in this context, we were looking at psychiatric hospitalization, because it's all well to say cannabis users have worse outcome as a group than non-users, but you don't see cannabis users as a group in your clinic. You see an individual patient in the clinic. So one needs to think of what does it mean for that individual, and this can generate an individualized risk score. And we are kind of now trying to validate in Spain, and we have some additional data from the UK that this is what it is. And again, this is in preparation, not yet published. So some kind of validation work. I won't bore you with all that, but this might be the way forward. So time for another question. If you please use the QR code and see what your, because now we are at a stage we want to think about treatment options. What treatment options would you typically consider for people with psychosis and comorbid cannabis use disorder? I don't know why it is not coming up here, but anyway, we'll move to the next question. Oops. What's happening? For some reason, this is not letting me move. Yeah, so here I would like to narrow it down further. Do you have any preferred choice of antipsychotics in people with psychosis and comorbid cannabis use disorder? Okay, while people are
we are submitting, but it is not showing on the screen.
Yeah, that's what I'm trying to figure out what's going on. Yeah, but I'll have a look at the results hopefully at some point of time soon. It doesn't seem to be reflecting on the screen. Some glitch in the system or a delay in it showing up on the screen. So let's move on. So to the next thing. So we looked at this question about which antipsychotics one might consider prescribing. And this is a review that we wrote, again, about 10 years ago. It was a systematic review. The key message is there that at that point of time, the evidence was not mature enough to suggest that choose one over other. Perhaps there was some evidence to suggest that clozapine was worth investigating properly in randomized controlled trials. Perhaps olanzapine might have had some benefits, but again, it was not mature evidence to suggest either way. More recently, another systematic review and meta-analysis. I'm not going to take you through all this, but just to indicate that this is out there, and some of the comparisons with olanzapine suggest that olanzapine might be better than some of the other antipsychotics, but this is all limited to what has been trialed before. Only on the basis of that, one can make these judgments. And some, for example, for negative symptoms, it seems like clozapine was better than some of the other comparators, but not a huge deal to choose from on the basis of current evidence. So again, this is also unpublished data. So again, this is a very small sample. This is not a randomized controlled trial. This is from data, observational data that we collected. And we could only compare people with three antipsychotics. Alipiprazole, risperidone, and olanzapine are the most common antipsychotics prescribed in the first episode psychosis population where I work. And it seems like there was some suggestion that olanzapine perhaps was better than risperidone, and again, also was better than aripiprazole. But again, this is observational data. The way we determined outcome is that we said that if somebody if an antipsychotic has been changed from one to another, that means the antipsychotic didn't work. Whether it didn't work because it actually didn't work, or whether it was not tolerable and hence the change was made. But overall, a discontinuation decision is indicative of broadly, very crudely defined ineffectiveness. And so on that basis, on that, using that as a metric, we found that perhaps, we found that olanzapine perhaps was better. But again, this is unpublished, so don't go by this data. And finally, I thought I will show this kind of cartoon where we have tried to think about some of the key considerations while prescribing in people with psychosis with cannabis use. Really asking the patient in greater detail, what are the most immediate triggers? Why do they use cannabis? What does it do for them? What benefit do they perceive from using it? And often patients will say that, yes, it helps me sleep. Without it, I don't get sleep. Or it might be that during periods of stress, whatever kind of stress it be, that's when they get back to cannabis. When there is no stress, they can manage. But when they are particularly stressed, that's when they have to have a spliff or a joint, whatever it is. Or so for some other people, it's they keep using because if they don't use, they experience withdrawal symptoms. So trying to understand some of those is really critical so that it helps them think about what else can be done for those kind of triggers that are particularly important for a given patient. Because this will be different in different people. Might there be a need for something to help improve their sleep so that they don't have to go back to cannabis to improve sleep? Because for whatever reason, their antipsychotic might be keeping everything under control, but yet they still have a sleep problem. Also, things like discussing whether they might be able to reduce the frequency of their use. Can they use less potent different types? And then exploring what's going on. Are they not adherent? Are they not responsive, even if they are adherent? And then think about appropriate strategies that one could think of. If they're non-adherent, can we think of depot medications instead of oral? If they are not responsive, can we think of switching antipsychotics? So kind of this is what I tend to think about in my clinical practice while thinking about how best to help someone with psychosis who has a comorbid cannabis use disorder. Some of you might find it helpful. Now, this is just an acknowledgement to my funders who supported our work, and really to the acknowledgement of the key people. This was our group some 10 years ago. We had gone out for a Christmas meal. And so these were the people who did all the hard work, and I get to present. So thank you. Thanks to all of you for listening. Very happy to take any questions that
Thank you
may
so
have.
much, sir. It was a wonderful presentation. We are over to shifting to chairpersons for their opening remarks. Your questions are invited in the chat box. So please type the questions in the chat box. Chairpersons, please.
Dr. Jayant, you want to start?
Sure. Thank you, Professor Shagnik. Yeah, you were right. I think this is a very different kind of presentation from what I got to hear when you were presenting a lot of the neurobiology, but I think extremely clinically relevant. I mean, just to summarize, I think definitely cannabis does worsens outcomes in psychosis. And I think also you've pointed towards many of the mechanisms, including antipsychotic failure, medication non-adherence, as well as possibly insight being one of the factors that contributes to why these worse outcomes really take place. Are we permitted to ask questions as well? I mean, just
Sure, sir. Sure. Up to you, sir.
yeah. Professor Shagnik, in the context of the factors as to why cannabis worsens outcomes in psychosis, you've spoken about insight. What about, did you look at how it affects positive and negative symptoms as well, and whether that might be the mediating pathway in a way which might also kind of worsen insight?
Yes, that's a really important question. So in this study, we didn't have um, PAN scores at the time points that we would need to assess. And again, I mean, there are lots of issues with these kind of studies because insight is not one fixed score. Insight fluctuates over the course of the illness. So this insight that we used in our analysis is the insight at that point of time. Now, we are assuming that across a range of patients, that broadly reflects their general insight, but which is not true. So there are some limitations to kind of interpreting these results too much. But to answer your question, no, sorry, we couldn't. But I think that's a really important thing to look at, that whether it is the positive symptoms or the negative symptoms, what is associated with poor insight in these people. Yeah.
Thank you.
Thank you, Professor Bhattacharya. I think there were a couple of serious comments, and I think some take-home messages before we go to the questions, which I wanted to make was the first thing when you showed your data about documentation, like, even if it's a simple yes or no. And I think all our junior colleagues, even, residents who are part of this webinar, I just want to emphasize the fact that, in the history taking, we must actually ask the question. Otherwise, the data that you showed in some parts of India, we do not know probably whether there's really no use of the cannabis or whether documentation is not there. The research can only help us only if we document. So the first take-home message should be we should start asking that question wherever we are. And sir, I think the other thing which I felt overjoyed in a way to hear you, because you are a true researcher who actually has been working fully in your hands there and then bring it back to practice. So really and your honesty and your modesty in saying, sometimes whatever we do, we do not have the clear evidence. And well, that is what research is all about. We work with it, we work with evidence, and things show. So Professor Bhattacharya, thank you so much for bringing this knowledge here. There are a couple of questions which I think people have asked as well. So I'll save my questions for the rest of the end of the talk, maybe. So Alim Bhai, will you be asking the questions which is coming? And I just wanted to know, why can't I see everyone? Is it my setting something is wrong, or?
Yeah, ma'am, anyone can, all of us can take up the questions and put it to Dr. Sagnik.
No, sorry, the screen setting, is it something from my part? Suddenly it's gone to spotlights.
You want to remove the spotlight? Is it okay for you now?
Yeah, I can see Shobhit Bhai now only. So is it my settings? Probably wrong. I'll
I
check.
think
Don't
yes.
worry. Okay,
Yeah.
thank you so much.
So Sagnik sir, risk of psychosis.
Please,
if
no, sir, please.
Okay, Dr. Sagnik. So
Sagnik is fine.
yeah, it will be difficult for us to do. Uh, risk of psychosis if medications are continued with cannabis. Question from Shobit. Shobit Garg, can you
Yes.
explain the question?
So, like, so patient is in psychosis on medications, and then so many a times they're on continued cannabis intake despite all the regulations. So, whether the risk, I know it's difficult to answer this in an ethical setting. So, observational data regarding this, sir, any?
Yeah, I mean, it's kind of, I think the fact remains that for some patients, there will be breakthrough psychotic symptoms if they're continuing to use cannabis despite being well treated on antipsychotic medications. It may vary from individual to individual, but the patient will be able to tell you perhaps that whether and if you are confident that they have been taking medications regularly in the prescribed dose and the dose was working before, then if they still have symptoms while they are using cannabis, then that's clearly a breakthrough kind of symptom that's no longer being controlled by the same dose that was effective earlier. So that might indicate that there might be a need to either cut down. Completely avoiding would be the best thing, but often that's not easy. But at least cutting down. Yeah, kind of discussions like such as the effect that the symptoms have on one's life might help them look at it in proper perspective. Otherwise, just um, talking about it like all smoking is bad for health doesn't really cut through. So I think it's really important to kind of personalize it to that individual situation.
Sir, Aleem sir's question, sir. So we generally ask this in rounds, how to differentiate like primary psychosis and secondary psychosis. So any context apart from the temporality, sir, anything from symptom characteristics or presentation characteristics can we, sir, distinguish?
Yes, sir. This is an age-old question. In every round, in every exam, if there is a case on cannabis, definitely it will get asked. So from you.
Yeah. It's a difficult question to answer, and I'll explain why I don't have a straight answer for it. So, of course, the easy thing, which I think most people do is, if it is possible, is if the patient is admitted to see kind of not start on antipsychotics and see whether the symptoms go away after a period of washout of the drug. That's one thing to say that, okay, at least this episode seems to be just drug induced and doesn't need antipsychotic initiation. But there is another way of looking at it. There was a study done by Robin Murray's group some years ago, more than a couple of decades ago, where they looked at substance-induced, cannabis-induced psychosis and kind of non-cannabis-induced psychosis, where they were certain. And to really answer your question, that in terms of clinical presentation, can we differentiate? And they didn't find that there was any robust differences that one could think of in terms of the clinical presentation. That is not to say that there may not be, but at least in their hands, when they looked at this question, they couldn't find any clear answers. And finally, one other viewpoint is that cannabis brings up psychotic symptoms in those who are vulnerable to develop psychotic symptoms. It is just one of the risk factors among many. We know that there are lots of risk factors for psychosis. And so from that perspective, these are people who might have psychosis anyway. And there is some evidence that those who have had multiple substance-induced, clearly cannabis-induced psychotic episodes, which seem to be self-remitting without any antipsychotic treatment, at some point of time, some of them go on to develop more chronic kind of psychotic disorder. Whether it's what one would typically describe, purists would describe as schizophrenia, is one could argue about that. But because it's also important to kind of note that to get cannabis, at least in the UK, and I'm sure it's the same thing in India also, one has to be really clever and smart and be able to get around in society to get access to the drug. And so these are people, cannabis using psychotic patients are often a bit more cognitively performing better than non-cannabis using psychotic patients, because otherwise they can't get access to the drug. And no parent brings it to their child. They have to secure access to maintain their drug use behavior. So perhaps they're different in that sense, that cognitively they are less impaired than people with schizophrenia.
I think Dr. Gautam Saha is here. He wanted to say a few words. Dada.
Hello.
Yes,
Hi.
Dr. Sagnik, excellent presentation.
Thank you.
I am asking a very clinical question because there are lots of patients came to us with a history of long-standing taking cannabis, and suddenly he developed psychosis. And another group of patients, after taking just first day or second day, they develop psychosis.
Yeah.
What will be the different, management, how to manage this patient in differently in these two groups? Number one. And what will be the duration of treatment? What you suggest?
Thank you for asking those questions, but you have asked very difficult questions. I'm not sure that I really have very evidence-based answers, but this is also very commonly seen that some people, even on the first or second episode of use, they start developing psychotic symptoms, while others, after a long time, perhaps some sort of a sensitization over time or a repeated dosing results in some sort of brain changes, which ultimately takes them over the threshold and results in the onset of psychotic illness. Now, in terms of antipsychotic, kind of, this is how I would look at it. I'm not suggesting that this is the only way that one should think about. I would look at it like if it is a psychotic episode, then one would have to treat with antipsychotics as long as one is clear that it is not a self-limiting remitting psychotic disorder once one is psychotic episode once the cannabis has washed out of the system. So assuming that the symptoms are continuing even after the kind of, and I know that in the clinical setting, it is very hard to do this. It's hard to say when somebody is very unwell to tell their parents or the family members, take your son and or daughter home and wait for a few days, let the drug wash out of the system.
Yes.
It's a very hard thing to do. So it's easier for people like me who work mainly in the, in an inpatient setting to try out all these things which come to our mind. It's very hard to implement them in real life. So most often you might end up prescribing some sort of antipsychotic, and the prescription of antipsychotic, I don't think that there has to be a great deal of difference in terms of choice of antipsychotic because of the nature of the presentation, except for it might depend on the, at least in the UK, it is very important to ask the patient what kind of antipsychotic and in terms of the side effects and all that. So that would be the main guiding, factor in choice of antipsychotic. With regard to your question, if it is the first episode of psychosis, then again, the usual things that one would want to give a trial of taking kind of stopping antipsychotic, because not all people who present with psychosis invariably end up having an enduring pattern of illness like schizophrenia. So one would want to give them a trial. But after how long, I think that's a difficult one to kind of, and there are no proper evidence-based answers. Many people think that at least for a year they should be on antipsychotic, and then depending on the nature of that episode, what kind of risks were there, what life stage they are in, might it have an effect if they have another relapse, might it affect their occupational functioning, might they lose a job, or those kind of considerations, and then discussion with the patient and family to see whether what is the right time to take that risk of slowly, very, very slowly tapering and stopping antipsychotic. But I would do it very slowly if this was somebody in my family. I wouldn't want to risk every episode of psychosis is very distressing for the individual. So I would be more careful about that. But surely, if it is just one episode, it would be important to give them a chance to see whether they can do without antipsychotics.
So there's a question.
Thank you so much. I just want to share one thing, one history more. We are also using, as we treat the first episode of psychosis, we do like this only. for this type of patients.
Of course.
At least 6 to 1 year treatment. But I'm sharing one my personal experience. I mean, I had my batchmate in MBBS had a cannabis, typically cannabis-induced psychosis, and he took, I think, 1 or 2 weeks antipsychotics. So now I'm 60s, he is also 60s. After that, no history of any psychotic episode. So that is also happened. That is my practical
Absolutely.
experience, I'm telling
Yeah.
you. It depends on the definitely individual to individual, but it is safe to at least minimum 6 months to 1 year
Yeah.
we have to.
Absolutely. Means if you think that it's very likely that it's a pure drug-induced psychosis, and once the drug washes out, then there is no point in, if one can try that, then there is no point in starting an antipsychotic in the first place.
Yes,
And
yes, yes.
I also remember from my medical school days, we used to have Saraswati Puja, and that is the occasion. And unfortunately, it's strange that in life, I used to be entrusted with the job of making the bhang
Bhang.
lassi in the hostel during Saraswati Puja, because
That's
I
right.
was not using any drugs or drinking alcohol, so they could trust that I would not take most of it myself. So everyone could trust me with that. So I used to do that, and then I was thinking that when I came to the UK, that's what I ended up doing as part of research. And I have had friends who had clearly very prominent affective symptoms, some psychotic symptoms as well, which lasted for about 24 hours, 36 hours,
Yes.
and then they melted away on their own.
Agreed, agreed. We have seen also. Thank you so much.
Thank you.
Thank you, sir. There is a question in the chat box. Cannabis used in patients with bipolar disorder. So, any comments on that, sir? How does it affect bipolar and any treatment intricacies?
Yeah, and again, that's another very common thing. So in our study, when we looked at psychotic episode, a psychotic disorder, we also subdivided them on the basis of whether they had an affective psychotic disorder as opposed to a non-affective psychotic disorder. And we didn't see, means of course, one has to be mindful that perhaps our sample was not powered to really look at an interaction between drug use and cannabis on the effect on outcome, but we didn't see anything to say that it was systematically different or any trend in that regard. So I would think that perhaps it has it has a similar kind of detrimental effect. If it is THC containing cannabis, detrimental effect on course and outcome in people with mood disorders, including bipolar disorder.
So, a couple of questions. Jayant also has put it a valid question. So, you said that cannabis results in reduction of insight and results in relapses. So, whether either way, good treatment, improvement in insight results in less cannabis roller coaster ride, sir?
Yes, we would all like that to happen, but I don't know whether it's a difficult one. I'm not sure that I have an answer that means kind of the natural expectation would be that if their insight improves, it might be easier to discuss with them, see them the effect of drug use on the course of their illness. So from that perspective, one would expect things to get better, but I'm not sure that there is any clear evidence that it does get better. So the hopeful clinician in me thinks that it should get better, but the hard researcher in me says that no, there is no evidence that it will invariably get better. But that's the hope that one would want to say. That's the reason why one would want to explain to family members that and to the patient that things can get better if you stop using. So yeah.
So from the chat box, use of CBD in psychosis and cannabis use. So use in glaucoma, and so if they're using in glaucoma, are they prone to develop psychosis?
So CBD, to my mind, as far as I know, that there is no evidence that CBD itself can induce psychosis. So And I know that it has been used in glaucoma. So unless there is THC, perhaps it doesn't have any, it may not have any effect in regular users who are taking it for glaucoma. With regard to CBD use in psychosis, that's something that we are trialing. We have done some previous work. There are lots of studies going on. I think, yes, kind of. I have been working on this for a long time now. So it would be nice if it actually, if there is robust evidence to show that it is beneficial as an antipsychotic. There is definitely preliminary encouraging evidence, but the evidence is not mature enough to say that yes, it works. It is too premature for that to explain this. If this was somebody in my family, I wouldn't necessarily jump into prescribing them CBD. I would first try the tried and tested antipsychotic medications, for which there is evidence that they work. But with CBD, we hope that it'll work, but evidence is not yet there.
So with
Sir, a very basic question, but sir, from an BSc psychology student, sir.
Yeah.
That does dopamine pathway has any association with cannabis-induced psychosis? A very conventional, but sir, your take on it, sir. Interesting.
Yes. Yeah. I think that's a really, really important question. Very, very valuable question. So it will be a slightly long answer. Now, all drugs of use work from different groups, like say Nora Volkow, and then later on David Nutt, who worked with opiates, showed that all drugs of abuse release dopamine, and that's why they are to different extents. With cannabis or THC, the amount of dopamine release is much smaller than one sees with something like cocaine. With THCs, I think there is only about a 4% signal change, which is really much smaller than one would see with cocaine. So clearly there must be something that is going on with the dopaminergic system. And once you look at the PET studies in regular cannabis users, there is and compare them with non-cannabis users, their D2 levels are different. So there is something going on there. Having said that, there are no CB1 receptors. CB1 receptors are the main molecular target for THC, which is the main psychotomimetic cannabis. There are no CB1 receptors on dopaminergic neurons themselves. So the likely effect on dopamine is an indirect effect through an indirect pathway. And we have done some work. So there have been 3 studies that have looked at THC-induced dopamine release. One study showed a positive effect, another study showed a no effect, and another was a SPECT study that had some equivocal kind of results. And then when these 2 studies that used PET, they combined the data, pooled data showed some effect, positive effect. That is the negative study and the positive study, when they pooled the data, they showed some positive effect. So there is some effect that is most likely there. And we have also seen some effect on one of my PhD students. His PhD was to look at a glutamate release. We think that's the most likely pathway, that through an effect on glutamate, any effect on subsequent dopaminergic neurotransmission. And so the short answer is very likely yes, but it's not a big effect. That is in contrast to the preclinical, the animal studies, where they show dramatic effect. So all the mice and rat studies, which is why people wanted to do these PET studies in humans, they show very clear effect. We don't see that in humans to that extent.
Sir, can you tell me the advantages of cannabis use in people over 50 with no previous history of psychosis? Question on the chat box.
Okay. Right. I'm not sure that there are any advantages of use of any of these drugs other than for, making you feel a little bit better. So if that is the advantage that one is looking for, yes, fine, by all means. But with regard to the specific question that if somebody is over the age of 50, then one is not at risk of psychotic symptoms and things like that. So let me point you to a meta-analysis that we did a few years ago. Because with CBD, which is perceived as harmful and even a potentially therapeutic effect, and the distinction between CBD and cannabis has been blurred. So there is quite a perception that all cannabis is harmless and may even be useful as a treatment. And there are lots of studies which use various formulations containing THC, CBD, and all that, or even just THC alone. THC has some beneficial effects of THC, CBD combinations in pain conditions, spasticity, etc. They are licensed as well for some of those, in addition to CBD being licensed for epilepsy. But when we looked at the pooled data from studies of people who were 50 and above, these were from independent RCTs that were done. We pulled the data and we looked at the adverse events reported in those clinical trials. These were all regulated clinical trials. So these were not observational studies. And so these were placebo-controlled clinical trials. We found that there was an increased risk of adverse events that was associated with THC-containing formulations in people over the age of 40, but that over the age of 50. But that's not the main thing that I wanted to say. The main thing was that there was a dose-response association between THC dose and certain specific adverse events in people over the age of 50. These adverse events being kind of thinking and coordination kind of disorder. So we interpreted those adverse events as almost like psychotic-like adverse events, but again, these are transient. These are not psychotic episodes or anything. These are transient thinking abnormalities that one could interpret as quasi-psychotic. There were some other adverse events as well associated with THC, particularly dizziness, sedation-related adverse events, and these were dose-response associations that we found. So that's my answer. So that's the relationship that we have found, and it's a dose-dependent relationship. So it's not just yes, no, but there is a clear dose effect. So take what you want from that.
Okay, sir, the question in the chat box, Bhang versus Ganja versus synthetic cannabis, any difference in association with psychosis? And if someone was using cannabis for 40 years at a similar dose, can the same dose induce psychosis at 60 years of age?
Okay, these are very specific questions. So I think in India there is, sorry.
Yes, sir, if you put it on a different angle, so whether delayed onset psychosis, so your take on it in context of psychosis, probably, sir, the chat box question means this.
Yeah. I'm not sure whether there is any systematic data for that. I told you that thing about people who were not recreational cannabis users, but they were given THC containing formulations and the dose response relationship with certain adverse events which were quasi-psychotic. So at least theoretically, it seems a possibility. But it is also to be considered that we know that as one grows older, the risk of the typical psychosis that we see in young adults goes down, though that doesn't mean that there is also a late onset psychosis that happens. Whether that late onset psychosis may also be, cannabis may also trigger something like that. I am not very familiar with that literature, so I would hesitate to say anything in that sense, in that regard.
Right, sir. Right.
I think we are at the end of time of the webinar. So any important questions? Otherwise, we can start winding up.
I think sir has been speaking for last 1.5 hours, sir.
Yes, absolutely.
We should consider that also.
True, sir.
So if you all allow, we can call it a day and start winding up now.
Thanks very much for the opportunity. It's really a pleasure. I just saw that one of my contemporaries from NIMHANS, Dr. Tirthali, Dr. Jagdisha Tirthali, he has left a comment. So he's now the head of psychiatry. So a very close, dear friend of mine.
Yes,
So
he's
thank
left a
you,
comment.
Jagdisha.
Thank you. So over to chairpersons for their remarks. Chairpersons, please.
Dr. Jayant?
No, I don't think there's anything much more to say. I think all that has been said has been said. I think it was wonderful listening to Professor Shagnik, and I think it's always a pleasure to kind of listen to his very studied and very methodical way in which he answers questions. So it is a real pleasure. Thank you, sir.
Thank you, Jayant.
Thank you. Thank you, sir. Thank you, Shaknika, as well, for a topic that has been fascinating. Always, we keep on. It's something very common in all our patients, and but something we keep on exploring and finding the answers, and actually getting. In spite of you saying that there may not be the answers, I think we did get quite a few answers today. So thank you for making it very clear with all the evidences you brought in, and even though cannabis is now being considered to be used in therapeutic ways, but I still think we need to be very cautious and still send the message across, send it boldly across as advocates that it is still a harmful drug and it should not be treated as lightly as still it is. And I put a comment, just before in the evening, we saw 40 kgs of cannabis in a household, someone, and it's not that uncommon, not so difficult to buy these days. So we must give a message, a united message that this should not be encouraged. Occasional use in hostels, that's all right on a holy night, just before a holy, but usually let's be cautious in our use. So thank you so much to the Thursday Musings team. You are an incredible team. Thank you to Professor Tofan Poti and all the members of Thursday Musings.
Thank you, ma'am.
Thank you,
Shobit, can
Rajashree.
you thank everyone from our side? Shobit?
Yes, sir. I think it is my pleasure. So first of all, my sincere thanks to Rashri ma'am, whom we were pestering to get sir into the platform, and I think madam has honored us, and it's such a great honor, sir. I think the one of the most prestigious researchers, come clinicians who have been in Thursday Musing platform, sir. And Alim sir was saying,
Thank you.
sir has a very heavy CV, and sir, I think we all should have cannabis dose before sir tuning us not to call you sir. So that is that is the biggest challenge, I suppose. And so with this, my sincere thanks to the chairs, Dr. Jayant and Rashri ma'am again, and my co-moderators and Tufan Pati sir and Orissa Psychiatry Society and so Torrent Pharma to cover this platform. I think so we have almost had 200 attendees in this so presentation, and so looking forward for your future interactions to you also, sir.
Thank you very much. Really, really appreciate the invite.
Great, great. But I request all of you, 30th should be hybrid mode, 300 episode.
And it's
Make
it has been such a
Some of us will attend in person.
it's such a long-standing endeavor, and
So proud of
hats
them.
off.
Yes.
Hats off.
So proud of them. Dr. Tufan Pati, Alim, Amrit Bhai, Shobit, Vishal, all are fantastic.
Sir, we will come to Calcutta, sir, then. Sir, at your base, sir, we will be there, sir.
Okay. Just tell us, we will organize.
Thank you, sir. Thank you so
Thank
much,
you, Dr.
everyone. I think it was a wonderful evening. If you allow, we can end the meeting now.
Thank
Good
you.
night,
Take
all of
care.
you.
Good
Thank
night.
you so much, Dr. Sajnik, Dr.
Bye
Jain,
bye.
Thank you.
Raj.
Thank you.